A very warm welcome to the third day of ESC Highlights. I'm Dr. Ashwani Mehta, and I work as a senior intervention cardiologist at Sir Ganga Hospital, New Delhi. The late-breaking science in hypertension, let's start with that. So very interesting studies came on day 3, and one of the very interesting study was the HERB-DH1 pivotal study. Now, this is for the first time an app-based study was done to manage the hypertension. And the aim was to evaluate the efficacy and safety of digital therapeutics using the HERB in patients, in the hypertensive patients. So what is HERB? HERB is an interactive smartphone app which has been designed to help users to make intensive and consistent lifestyle modifications to reduce blood pressure. Because we know, that lifestyle modifications are not easy to maintain. So what this app does is it helps these patients and gives them suggestions to make intensive and consistent lifestyle modifications. So very interesting study. About 390 patients aged 20 to 65 years diagnosed with essential hypertension were randomized to this digital therapeutic versus the control group. And the assessment was done by ambulatory blood pressure at 12 weeks. And what they found that the changes in the blood pressure were greater in those patients who were in the digital therapeutic group, the ones which were using the app. And interestingly, they also found that the need for hypertensive medication was lower in the digital therapeutics group. So this is something which is very new, and it highlights the potential for the various digital interventions, including the apps, for the non-pharmacological lifestyle modification in hypertension. Now, another very interesting study in hypertension was the QUADRET, and the QUADRET looked at the quadruple ultra-low dose treatment of hypertension. We know today that low dose combination therapies is the way out to treat hypertension. And this study by the name QUADRET study was carried out to estimate whether the hypertension management started with a single pill containing 4 standard dosages of BP lowering medicines, which were very, very low, the ultra low, rather than the standard. The quarter standard dosages were used, and this combination was called quad pill. Now they looked at that whether this is more effective approach to control blood pressure than the standard monotherapy. And what it contained was 37.5 milligrams of irbesartan, the amlodipine 1.25, indapamide 0.625, and bisoprolol 2.5. The primary outcome in this study was the change in the mean automated blood pressure, systolic blood pressure at 12 weeks. And what they found, their strategy of starting with quarter dose quadruple combination was much more effective in lowering the blood pressure compared to the common approach whereby the standard monotherapy was used. So interestingly, this opens way for starting an ultra low dose quadruple therapy in hypertension right in the beginning. Another very interesting study, which is very important from the lifestyle modification point of view, was the DECIDE SALT study. And this looked at the impact of salt supply on blood pressure in residents in a senior residential facilities. Now, what they really did was they give one group the normal salt and they replace the salt with salt substitute in the other group. And what they found that the salt substitute reduced blood pressure, and not just that, there was also a reduction in the cardiovascular event. And this came at about reasonable safety. Although, there were some chances of increased hyperkalemia, which was biochemical, but it was not evident in the adverse effect. Now, in this study, what they found that if the salt substitutes were used, it caused a fall in blood pressure by about 7.1, which is quite significant in the mean systolic blood pressure, and it is statistically significant. And also, it also meant that in the unrestricted supply group, the mean systolic blood pressure was lower than the usual salt group. But then this did not reach any statistically significant value. So on one hand, they looked at salt substitute versus the usual salt. On the other hand, they looked at the restricted supply versus the usual supply. And what they found that salt substitute was more effective than the restricted supply of salt. Now, this is something very interesting, which means that even if you restrict the intake of salt, it may not be as effective. Whereas if you substitute the salt by the other salt, which has low sodium, it could be more effective in reducing blood pressure. And also, it could also reduce the cardiovascular events. So this is a new era of using the salt substitutes, which has been proven decisively effective in reducing the blood pressure. We know that managing hypertension is difficult. And we also know that the single pill combination therapies, that is 2 or more than 2 drugs, was recommended in 2018 in the European Society of Cardiology ESH guidelines. And despite this, still, we know that there are a lot of patients who are still not controlled. So this particular paper looked at now, 3 years later, where do we stand? Now, if you look at the guidelines, now, despite these guidelines, the single pill triple drug combination prescriptions have not been that high. Although in India, we do have lots of such combinations, but these single pill combinations in Europe and other parts of the world are a little restricted. And what they found, that there was a significant impact of a single pill combination. And they looked at this impact and they conducted a systematic review, which assessed whether the single pill combination therapy led to improved adherence and a better blood pressure control. Now, this was compared with a free equivalent combination therapy in patients with hypertension. So on one hand, patients were receiving the single pill combination, and on the other hand, they were receiving the free equivalent combinations. Now, they looked at patients of hypertension more than 18 years of age, and what they found was that the single pill combination leads to a much better adherence and persistence as compared to these free equivalent combinations. And obviously, when there is a better adherence and persistence, the control is much better. Now, they also looked at the difference between the cardiologist's prescriptions and the GP's prescription for treatment of hypertension. And what they found, that when they analyzed the cardiologist's prescription, they found that even among cardiologists, close to 50% of prescriptions still are monotherapies, and the bitherapies are somewhere 33%, and the tritherapy is 12.9%. So interestingly, even among cardiologists, the use of triple pill combination is less compared to the single or the double dose combination of various drugs, double drug combinations. Among GPs, in fact, this was much more pronounced. And what they found, that about 67% were using single monotherapies, and just about 23% were using the dual combinations, and just 7.4% was using triple combinations. So although there was a change among cardiologists of use of more combinations, but still it was much less than expected. We know that the lack of blood pressure control is related to various factors, and the patient-related barriers are there. The physician-related barriers are there, and there are also barriers in healthcare systems. And what this fixed drug combination does is, it offers a solution by offering a low-dose triple therapy in a single combination And in fact, it could be a very good way to control blood pressure right in the beginning. And one could start earlier with this triple combination to achieve a better blood pressure control. And if you look here, this is single pill combinations, which was studied in the ASCOT study. And very nice, very robust data. And it talks that even after 20 years, the single pill combinations are effective. And not just effective, they were quite good in reducing the cardiovascular mortality by about 21%, and also the stroke by about 29%, the atrial fibrillation by 9%. And at 20 years again, you see this effect of perindopril and amlodipine combination in ASCOT trial. Uh, it is still being seen, and the legacy of this ASCOT trial continues even after 20 years of combination. Now, if you look at the guidelines favor ACE inhibitors in majority of clinical scenarios over the ARBs, whether it's 2018 ESC guidelines for management of hypertension, which have placed ACE and ARB almost at the equal setting. But in 2016 guidelines for diagnosis and treatment of acute and chronic heart failure, they show that to start with ACE and to give ARBs in case patients is intolerant of ACE inhibitors. The 2019 ESC guidelines for chronic coronary syndrome also talk of ACE, and to give ARBs only if it's intolerant, patient is intolerant to ACE. The 2017 guidelines of acute MI presenting with ST elevation, the first choice is ACE and the ARBs only when the ACE is intolerant. The 2019 guidelines on diabetes, pre-diabetes, and cardiovascular disease, which were developed in collaboration with EASD, again talks of using ACE first, and if the patient is intolerant, giving them the ARBs. So, if the patient has hypertension and AF, if the patient has coronary artery disease and AF, or if the patient has congestive heart failure and AF, then it's very important to give this particular combination. And specifically, the ACE inhibitors have an advantage here. Now, we also know that it's a myth that the triple antihypertensive combination should be reserved as a weapon only for resistant hypertension. I think it's quite good that initial combination, we know there's a three-step approach which has been proposed. As the first step, the initial combination either of ACE-ARB plus calcium channel blocker or a diuretic should be considered in patients with grade 1 hypertension, or if the patient is very old or frailer, then you can consider monotherapy, but otherwise you can use this combination as a first step. Then, as a second step, you can combine the three, either ACE-ARB, calcium channel blocker, or a diuretic. And as a third step, if there is a resistant hypertension, you can add spironolactone or other diuretic, and maybe you can consider adding alpha blocker, beta blocker. Now, this is all in the resistant hypertensions. And this guidelines also says that beta blockers should be considered at any treatment when there is a specific indication for their use, like heart failure, angina, post-MI, atrial fibrillation, younger women, or those planning the pregnancy. Now, another very interesting trial came about was a Tomahawk trial. Now, this was one trial which looked at immediate angiography out of hospital cardiac arrest. And the aim was to examine whether immediate coronary angiography for treating or ruling out the ACS, the acute coronary event, in out-of-hospital cardiac arrest survivors without ST elevation is beneficial for all-cause mortality at 30 days compared to the initial ICU assessment and delayed or selective angiography. Now, it looked at patients aged 30 years or older who had a successful resuscitation and a probable cardiac cause of arrest, and 554 patients were randomly assigned in 1:1 ratio, either to immediate coronary angiography or initial ICU assessment. The initial ICU assessment was followed by a delayed angiography if required. And they looked at the all-cause mortality at 30 days, which was the primary endpoint. And what they found was that among patients with resuscitated out-of-hospital cardiac arrest of possible cardiac origin with shockable or non-shockable arrest rhythm and no ST elevation, a strategy of immediate unselected angiography did not find to be of any favor. In fact, it was not found to be beneficial over delayed and selective approach. Now, this is with regard to 30-day risk of all-cause death. And the select endpoints were also looked at 30 days, the neurological deficit and all that. And at 30 days, the composite secondary endpoint of all-cause mortality or severe neurological impairment was more common in the immediate angiography group. So the findings of this Tomahawk trial do support results from a previous randomized trial by the name COACT in such patients, which did not find any difference in the clinical outcome of immediate or delayed angiography at 90 days and 1 year. So it is on the same line, and all the patients who are resuscitated out of hospital probably do not require an immediate angiography. Now, another very interesting treatment is the RAS inhibitors. And we know one of the limitation is hyperkalemia. So one interesting paper looked at getting to the heart of clinical inertia in management of RAS-induced hyperkalemia. And we know that hyperkalemia is quite common in patients who are on RAS inhibitors. And if they have renal failure, in various trials, whether it was RAILS, emphasis heart failure, they all had significant patients who did have hyperkalemia. And if the patient is elderly, patient has hypertension, diabetes, he's on renal medication or has increased disease severity, we see much more hyperkalemia. And it is common in patients of heart failure and is associated with disease severity and impaired renal function. And also it causes a suboptimal use of RAS inhibitors. And when there is a suboptimal use of RAS inhibitors, we do not achieve the recommended doses. In fact, what it does is it reduces the cardiac outcomes, the cardiorenal outcomes, and it is not associated with good cardiorenal outcomes. So the question is whether there is any role of potassium-lowering drugs in such group of patients. We know that there is a possibility of using diets which are low in potassium, but they're very difficult to follow. There are some overall potassium dietary recommendations which are easier to adhere to, but not really make much difference. But the new potassium binders are helpful adjuncts to facilitate and maintain RAS inhibition and even up titration. These new potassium binders can facilitate the addition of MRAs to patients with true hyperkalemia or who are in a high likelihood due to impaired GFR. And another important point is if you look at the safety profile, the side effect profile of both potassium binders, which are there in the market, it is acceptable. So it's a new way of treating RAS-induced hyperkalemia with potassium binders, which can lead to a better treatment in such patients. Another interesting study which was presented was the Hotline SSASS study, and this looked at the salt substitute and stroke. Now this comes in addition to the earlier salt study which I've just described, and it compared the effect of reduced sodium salt substitute versus a regular salt on stroke, cardiovascular events, mortality, and clinical hyperkalemia. It was an open cluster randomized trial that enrolled patients between April 2014 and January 2015. And the participants had either previous stroke, age 60 years and above with poorly controlled blood pressure. and approximately 35 individuals were recruited from each of the 600 villages for a total population of 20,995 participants. Now, these participants were randomized in 1:1 ratio to provision of salt substitute or continued use of regular salt. Now, what they did was they looked at the risk of stroke. The risk of stroke was reduced with salt substitute compared to regular salt. And regarding the secondary outcomes, the major cardiovascular outcomes such as non-fatal stroke, non-fatal acute coronary syndrome, vascular death, they were all reduced when salt substitute was used. Now, this is something which is very interesting. And it is now evidence that using salt substitute could help us in reducing the major cardiovascular events. And they did look at the safety. And regarding safety, there was no increased risk of serious adverse events attributed to clinical hyperkalemia with the salt substitute compared to regular salt. So replacing the salt with low sodium alternative offers the risk of lowering the risk of stroke in patients with high blood pressure or prior stroke. So again, a very interesting and something very new that the salt substitutes can offer us reduction in the new incidence of cardiovascular events, including stroke in patients who are at a high risk, who have already had stroke, or who are having high blood pressure. Thank you so much for your kind attention.